Okay, so I will tackle this and then I'll ask you, Finn. Now, for small bowel, we have got various kinds of examinations which we can prove, and you people should know what are these. And we can, in the barium world, we can do a barium meal follow through. A barium meal follow through is simple, where we just give oral barium and follow it through the small bowel. Then we can do a small bowel enterocolysis, also previously known as small bowel enema, where we put in a tube into the proximal duodenum. Then we give double contrast. We use methyl cellulose, and it gives a lot of distension of the small bowel. It's a very good study. But the patients, of course, they don't like it. Nobody likes a NG tube going in and to then manipulate it into the proximal duodenum. Then we have got a CT enterography, simple, where we use oral contrast in and then we do a CT in a portal venous phase. We can also do a CT enterocolysis. Very few people are doing it, where we put in a contrast, a tube, just like small bowel enterocolysis. And then on MR also similar techniques can be done. MRE I am going to teach you because MRE is now very important for the exam. But MR enterocolysis, very few people are doing. Again, same technique. So these words should be in your vocabulary. Now, as far as jejunum is concerned, please remember the difference between jejunum and ileum. We know that there are valvular conjunctives in the jejunum, and the number of valvular conjunctives in the jejunum is much more than in the ileum. And this is important for you to remember for your exam. And a few films will come in the exam around this concept. Also remember the concept of mesenteric border as well as anti-mesenteric border. So mesenteric border is, of course, to the side of the mesentery, and the other one is anti-mesenteric border. Most of the pathologies, they happen at the mesenteric border. Anti-mesenteric border, remember Meckel's diverticula. That is important for the exam, anti-mesenteric border. And otherwise, pseudosaculations of, let's say, scleroderma, they happen on the anti-mesenteric border, or at times pseudosaculations of Crohn's disease, they also happen at the anti-mesenteric border. So I will show you these concepts, but always remember Meckel's diverticula. This is a barium meal follow through. You can see that normal feathery pattern of the jejunum, and as we go distally, you can see that there is paucity of the valvular conjunctives. Now, this is small bowel enterocolysis. No investigation shows the mucosal pattern of the small bowel as well as a small bowel enterocolysis. They can show you in the exam. I don't think so. Very few people are doing it now, and very few people have the skills to do it. Basically, methyl cellulose is used with buscopan, etc., to give this coating. But small bowel enterocolysis is very good to teach you anatomy and some findings. So if you just concentrate on this concept, and this concept is a very important exam concept, that on this spot film of small bowel enterocolysis, you can see that these are the jejunal folds. Now, this black thing here is the valvular conjunctiva, and this is the space in between. If I show you this diagram, so this is that valvular conjunctiva, and this thing here is the space where the barium is. So this is known as interspace, right? So this is the mucosal fold. This black thing is the thickness of the mucosal fold. So number one, see how many mucosal folds are here. It is written per inches, and there are 4 to 7 per inch. 1, 2, 3, 4. 4 to 7 per inch. But in ileum, these are 2 to 4. Second thing is, look at the thickness of the fold, and you will agree that this is more thick as compared to this one, 2.5 versus 2 millimeter. So this concept is important. Candidate 8, classical exam film. Because of time factor, I'm going to ask you leading questions. This is a small bowel enterocolysis. Contrast is, so there is a catheter in the duodenum. And what is your finding?
So I'm presented with a spot film of small bowel enterocolysis with a catheter seen in situ. This, as you told, is in the jejunum. The striking abnormality that I can see is that the jejunal folds are not what we expect to see. So there seem to be less valvular conjunctives.
Excellent.
Yes, so that means that the folds are less.
And
that should be expected
what
in the
comes to
jejunum.
your mind here?
So the top thing that comes to my mind would be that this is reversal of the fold pattern which occurs in celiac disease.
Excellent. So in celiac disease, what happens is that there is atrophy of the villi, and then there is what we call jejunnization of ileum. And this film is a favorite film for the exam. Even this is a second case in which, look at the proximal fold, there is no, though it's single contrast, but more distally there is so much. Here, distally there was much, and here there was no fold. Do you think this is malignant or benign? Candidate 8.
The stricture appears to be short segment and irregular, with some shouldering as well. And if the patient is a known celiac disease, I would kind of suspect it to be malignant as well, until and unless ruled out, because it has more association with lymphoma or carcinomas of the bowel.
Excellent. So celiac disease also is, it is associated with lymphoma as well as carcinoma. This is a classical malignant stricture where there is apple core appearance, overhanging edges, etc. Okay, this is a case of Crohn's disease. First of all, this is the terminal ileum. But what is this where I am pointing out? This thing.
Is this like a spot magnification kind of thing?
Okay, so this is a classical exam question. They will show you terminal ileum film with a compression device, and this is that compression device. And this device is needed so that the loops do not overlap the ileocecal junction. Now, with that background, this is a case of Crohn's disease. You tell me, why is it Crohn's disease?
Okay, so on this spot film with magnification view of the terminal ileum and ileocecal region and some part of the large bowel as well, I can see stricturing in the area of terminal ileum with some luminal narrowing, and possibly some aphthous ulcers in between where there is less filling of the contrast.
Okay.
There is further stricturing which I could see in the part of the large bowel that is seen. Could be could be in the transverse colon, yeah.
No,
like
this
just
is
above it.
another loop of small bowel.
Okay. So, all right. So if that is a loop of small bowel, still I can see some narrowing and stricturing in that part as well. So if that's a stricture as well, that would represent a skip lesion.
Okay, well done. So now Crohn's disease, please remember that one Crohn's disease can happen anywhere from oral cavity till the anal canal, number one. Number two, Crohn's disease inflammation is transmural. So it goes through its deep ulcers, which you will see, and means it can penetrate through the serosa, and that is why there can be so many fistulas. The fistulas can be because in between bowel loops. It can also be a cutaneous fistula and things like that. So, and when we will cover ulcerative colitis, there you will understand that ulcerative colitis is only superficial ulceration. Now, skip lesions is another thing which is quite pathognomic for Crohn's disease. So, skip lesions means that there will be areas which are normal. Now, what is happening here is that there is a stricture which looks like sort of a close to a fibrotic stricture and very smooth. This is the mesenteric border. This is the anti-mesenteric border. We call it pseudo-sacculations, which can happen, fibrosis, which happens on the anti-mesenteric border. You can see this stricture here. And then there is a skip lesion, and you can see these aphthoid ulcers. Aphthoid ulcers, wherever you see them, and they have come in the exam again and again, small bowel, large bowel, whatever, Crohn's disease should be up there. And aphthoid ulcers, by definition, are deep ulcers. Remember that. So in ulcerative colitis in large bowel, you will not see them. So this is the differential of aphthoid ulcer. This is the differential of ileocecal region thickening. Please remember that ileocecal region abnormalities. So I am basically from Pakistan, and in Pakistan, or let's say in India or subcontinent, if you see anything in the ileocecal region, you call it TB, because TB is so common there. And I remember back home, we never used to call it Crohn's disease, and it's vice versa in UK. So remember that here it's vice versa. It's Crohn's disease, Crohn's disease, Crohn's disease, unless proved otherwise. That does not mean that you should not include in your differential. So you should know a few discriminators between TB and Crohn's disease, and we know that more involvement of the cecum is one of the discriminator. It can mimic, by the way. That's number one point to remember. But otherwise, necrotic nodes, more fistula, things like that. You might get with this a TB. You might get X-ray film as a long case and things like that. So TB of ileocecal TB in UK is rare. Crohn's disease is very common. Having said that, you have to keep both of them in your differential. Now, I am going to teach you something here which will help you to pick up an exam finding. In Crohn's disease, what happens is that ulcers are deep ulcers. And some of these ulcers can be very linear. Look at this ulcer. Actually, this is an ulcer, and the mucosal folds are radiating towards it. It's a deep ulcer. It's knife, just like a knife edge or thing, stab type of a ulcer. With that comes this classical exam finding. Yes, candidate 8. How will you describe this? This is a classical exam finding.
So I'm presented with spot films of barium enema or follow through, which I cannot make out on these images. So there is abnormality seen involving the bowel loop, which appears to have thickened folds, irregular mucosal irregularity, and multiple outpouchings outside the lumen, which may represent multiple aphthous ulcers.
What do you call this appearance?
So this appearance is called, edematous mounds of tissue. So this is called cobblestone appearance.
Right. Okay. So thank you, candidate 8, and next is candidate 10. Now, this is, first of all, if you see, I showed you one ulcer, which was what we call a linear ulcer. Now, look here, what is happening. There are so many ulcers. This is one ulcer, second ulcer, third ulcer, and with that there is edematous, mucosa, gives you this cobblestone appearance. If you see these in profile, look at this. This is that rose thorn type of an appearance. Look at all of these which are in the profile, which are projecting outside. What does it tell you? They are going into the wall. So this is intramural and these are deep ulcers. So this is Crohn's disease. Okay, candidate 10, over to you. Classical exam film.
Okay, so this is a spot image in the pelvis, in a 40-year-old female. There are filling defects in the region of the terminal ileum, extending into the cecum. There appears to be a sort of contrast extending from the small bowel loops into the what looks like the bladder, the urinary bladder. This could be in keeping with a fistula.
Okay, very good. What's happening in this region? This is the ileocecal junction.
So this is not much contrast of classification. It could be suggestive of ulceration or strictures in the terminal ileum.
So if this is the terminal ileum where I am pointing out, there is a stricture there, then what is this? And what is this? And what is this? So first of all, what is this?
Terminal ileum?
Basically, what I'm asking is, there is a connection. So this is the terminal ileum. I'll take over, please. This is the terminal ileum, and this terminal ileum has got a stricture. And then there might be a bit of obstruction because there is upstream dilatation. With that, there is a connection between this loop and this cecum, and this is a ileocolic fistula. Another ileocolic fistula is this one, and then there is an ileal fistula here. You have picked up this very well, where you picked up that there is a contrast in the urinary bladder where it should not have been any contrast, and then you can see a faint outline there. Please remember, in the exam they will show you contrast in the bladder without any fistula, but you can infer that there must be a fistula. So this is a case. So I will show you various examples of fistulas and on various modalities because they are classical for your exams. So I want to develop your eyes, and I'll show them on barium and CT and MR. So we know that this is Crohn's disease. What is your finding, candidate 10?
So the multiple fistulas extending from the distal sigmoid colon to the terminal ileum in keeping with...
Right. So it's, if basic pathology is here in the ileum, and there is a chronic type of fistula, and then there are two connections. So ileocolic fistula. So the basic pathology is in the ileum. Okay. Again, similar to previous, just tell me the fistula. Between what and what?
Between sigmoid and terminal ileum, so ileocolic.
Okay. Now, one thing is that in the Viva, they can ask you that what kind of a film is this? And if you go to barium enemas, to outline the rectum, we do a 35-degree angulated film, and this is that film. Number two, sometimes we do prone films, and this is a known pitfall in the exam. They can show you follow-throughs, they can show you enemas where your anatomy changes and the cecum might be sitting on the other side. So beware of this, that it might be a prone film. And so there is a stricture here, and then there are strictures and fistulae formation. Okay, spot film, candidate 10. What is abnormal on this? Barium may follow through, but what is abnormal?
There's contrast in the urinary bladder.
Excellent. So that means there is a fistula there. Okay, I am going to show you a CT scan, and this is a brilliant film of a CT because so many films now come in the exam where once you know the same pathologies, the same pathologies where you can see on a barium, you can see on a CT scan and things like that. So candidate 10, can you see the CT? PACS case 3 written on your screen?
Yes.
Okay, so I will tackle it, and it's a sort of a, sorry, I have shared a wrong screen with you. So can you see these CT images?
Yes.
Okay, all of you please concentrate, and this is the type of film or a case which will come in your long cases also. So this is an incidental finding, I'm not worried about that. Now, if you see, look at this loop, and this loop has got a bit of a, we call it small bowel feces sign, where there is some material within the small bowel. You can see a bit of thickening, and then you can see this acutely inflamed loop of ileum, and you can see this Coombs sign. We call it the Coombs sign, where the vasa recta, they are enhancing. Fat around end, this is mesenteric fat, which is around this loop. They say that it is pathognomic for Crohn's disease. There is no differential diagnosis. Another thing which is visible. Now look at this loop, and how does this continue here? This is the ileocecal junction. But I am more interested in what is happening in the mesentery. So there is a, transmural, definitely abnormality where an abscess is sitting here. And this abscess is in the mesentery, a lot of fat standing. And then this is extending. Now, this is the sigmoid colon, and you can see it is abutting the sigmoid, just like, and you might, right now we cannot see it, but there might have been a fistulous communication. At least these two loops are adherent to each other. Then as I am proceeding further, you can see this abscess with rim enhancement. Where is it sitting? This is the urinary bladder. It is sitting on the posterior surface of the urinary bladder. Right now, it is not fistulating into the urinary bladder, but you can infer that, in a few days' time, it might, and then you will see air inside the urinary bladder also. I'm not interested in these ovarian cysts. These are incidental findings. Now, if you see this coronal, and again develop your eyes on this, lot of fat standing, and that Coombs sign, etc. And you can see this was that mesenteric abscess, and you can see how it is communicating. This is that abscess which is sitting on the urinary bladder, and this is the sigmoid colon. So, so, and on a so this CT scan tells you that CT is quite a robust investigation to show you uh, everything regarding uh, Crohn's disease case and things like that. And many a times they will show you in the exam. Right. Let me close. Candidate 10, are you with us?
Yes.
Okay, now candidate 11, are you with us? Can you raise your hand? So candidate 10, thank you very much.
Yes, can you hear me?
11, this is a case of Crohn's disease. This is an MRE study. Two sequences have been given to you. This is a T2 weighted sequence. This is a post-contrast sequence. What are your findings, please?
Selected images of MRE. It shows a mucosal hyperenhancement pattern, which is a sign of activity in Crohn's disease. There is vasa recta with fat stranding and engorged vessels.
And what is happening here? For example, here.
There is a fistula tract with anterior colic fistula.
Okay, so this is an MRE study where there is a long segment stricture with acute inflammation involving the terminal ileum. Maybe portion of the cecum is also involved. As correctly pointed out, that there is hyperemia. This is that Coombs sign. You can see multiple loops which are adherent, possible fistulae, ileo-ileal fistulae. So here I am going to teach you a bit about MREs. Please remember that MREs now are bread and butter in the exam, and many a times they have come in the exam. In MRE, what we do is, for example, in my department, we are using mannitol, but you can use many things, and about 10 different things have come in the literature where people have used juices, milk, and many things, but we use mannitol. And basically, we give about 1300 ml of mannitol over a span of about 90 minutes or so. The idea is to distend the small bowel with fluid, and we give then buscopan, and we do scanning. The sequences which we do include T2s, two different types of T2s, and we do a fat saturated T1, and then post contrast, we do coronal as well as axial. What a key sequence for you to remember, which is a Viva case, is the DWI. In DWI, what we do is that we do 4 kinds of DWI. This is B0, so the B value is 0, B50, B500, B1000. There is a bit of typo here, so this is B1000. Please remember that there is no hard and fast rule, and various departments use their own parameters. But this will give you an idea. You are increasing the B value. That is the main point. There is a lot of literature about how do you differentiate between fibrotic stricture versus an active stricture. And this is a Viva question also. And the answer is a DWI sequence. Now, if you look here, there is a stricture here and it enhances on post-contrast. Please remember, a fibrotic stricture can also enhance, though it will not be very thick, etc. But on a DWI sequence, there is a black and white difference between a fibrotic or an active stricture. And so here, this is from literature, where you can see restricted DWI, high signal on DWI and low signal on ADC map. This is a very important Viva question, and this is a very important question in your day-to-day life, where surgeons will ask you in the MDT that is it fibrotic or not, because if it is still active, the patient might still be a candidate for what we call medical treatment. If it is fibrotic, then it is surgical treatment. So candidate 11, if you can tell me, there is a stricture here. This is T2 weighted sequence. This is post-contrast sequence. So we were worried if it is active or fibrotic. B0, B500, B50, B500, B1000. What is your inference?
Okay, this visual tract show low signal intensity on T2. I couldn't see fair contrast enhancement, and it shows no restricted diffusion. So I think this is a fibrotic stricture.
Okay, so the idea here was to teach you how to infer the diffusion weighted. What you do is you look at the finding on B0, then look at the same finding. So this is that stricture, right? Many things are high signal on B0 because anything which is high T2, which will be high on B0, as the diffusion weightage is scanned, just concentrate here. Then B500, just concentrate here. And B1000, and still it is showing restricted diffusion. So the answer is that this is an active stricture. So the take-home point was that how do you pick up restricted diffusion? This is how it should continue showing high signal on the highest B value. Please remember the same concept we will see in liver imaging also, where we increase the B values and we will say restricted diffusion when it continues high signal on the highest B value. Okay, this is your last film. Now, this is a spot film of a barium meal follow-through. I just want you to describe if there is mucosal thickening or not. Over to you.
Yes, there is a mucosal thickening.
Can you describe radiological findings? How will you describe in the exam?
Okay, there is spiking from the mucosa, and there is pulling of contrast, like there is a visual tract. I couldn't identify this bowel loop. However, there is a thickening and there is a spiking with thumbprinting appearance.
Excellent. Well, thank you very much, number 11. Next will be number 12, but let me take over on this case. Now, go back to the basics, and this is the idea here is to develop your eyes. How will you describe it? This is a vulvary conventi. Now, in between these two, the villi, in between these two is this space, so the barium will go in. So look at this loop, the barium will go in, and this is the thickening of, so this shelf-like opacity is the fold itself. Now here what is happening, this fold is thickened and this fold is thickened. So I will change to arrow to be able to show it to you clearly. Now this shelf here is the thickened villi, and this one is another one. So the spike of barium, which is in between, you can see that it is now narrowed. So these thickened fold, thickness of the fold has increased. Second point is, as very well pointed out by candidate 11, that this is the mesenteric border and this is the anti-mesenteric border. If you can see here, these are thumbprints. And thumbprinting will always be more common on the mesenteric border, right? So this was just to develop your eyes on this finding. In your previous Chapman, there was differential diagnosis, rather two differential diagnoses, thickened fold in non-dilated small bowel. And we are in that territory. It's quite a non-specific finding, but you have to, sort of develop your eyes. This is a case of hypoalbuminemia of any cause. If you go here, you see this edema hypoproteinemia. So hypoproteinemia is the most common cause which you will see, where you can see these thickened fold. So this was just to develop your eyes. Another case, and this is eosinophilic enteritis. So nobody is going to show you in the exam, but I wanted to show you an example of similar thing on an MR, where if you go back, you see this thing, eosinophilic enteritis. It's not a FRCR 2B case, eosinophilic enteritis, but this is just for differential diagnosis. And in this, you can see the same finding here, and same finding here on an MRE also, thickened fold. This, on the other hand, is a case of celiac disease, and it is interesting because similar to what we have picked up earlier today in barium meal follow-through, you can see that the proximal jejunum hasn't got, this is jejunum, no mucosal folds. And more distally, look at the ileum, jejunization, look at the ileum. So this is MRE of similar case. Now, if an examiner has got a good MRE examination, then particularly with a tumor, etc., might show you. So you might pick up the tumor, and then the question will be, what is the association and things like that. And the eye see what the mind knows. So this is why I'm showing you this example, that celiac disease can also come as a sort of a on MRE. Right. So those of you who are leaving now, if you can, the feedback is form is here, and if you want to scan it and complete the feedback. Yes, please. Number 12. Number 12. Are you with us? Okay. Now, number 12, I cannot. Have you raised your hand, number 12? Yeah, I can now see you. Yes, number 12, are you with us?
Yes, I am, yeah.
Okay. Now, this case has got, this is post-radiation change. There is a stricture here. What do you think is happening here? How will you describe this?
So on the spot images from a barium meal follow-through, in the valvuli convenientes, they appear to be, there is thickening of the mucosa, and I can see the valvuli convenientes where you've marked with the pointer, and some thumb printing as well.
Thumb printing also, very good.
Yeah, and mucosal fold thickening and some irregularity in the mucosa as well.
So my question is regarding the concepts. This case is a post-radiation case.
Yeah.
How do you explain all of these findings in post-radiation?
It's a fibrosis as a result of radiation.
Okay, so let me tell you, if you remember this concept, you can make your radiology. It's basically, it is vasculopathy. You know, small vessels, they are affected by radiation, and it is an ongoing process. So it's an acute over chronic process. And when there is an acute process, what will happen? The capillaries will become leaky, or there can also be intramural hemorrhages because capillaries might leak blood, and because of that, you can see these mucosal thickenings, like this, and also thumbprints. And then there will be chronic changes where you will see fibrotic stricture. Now, post-radiation change has come in the exam again and again and again. And in this particular case, you can see that there are long segment strictures. Candidate 12, do you think that these are malignant stricture or benign stricture? Appearance-wise, I mean to say.
So the bowel loops appear featureless, and I can see multiple strictures, and they're quite, at few points, they're quite long strictures and they're irregular. I can't see any typical shouldering in them. So I'm thinking that as there is a history of radiation, this is like radiation-induced strictures.
Right. And what do you think about this loop here? Is there a bit of mucosal thickening?
Yes, there is mucosal thickening there, yeah.
Right. And what is happening here? Is there a bit of obstruction?
Yeah, proximally the loops are dilated as well.
Okay, so now this is a classical example where you can see chronic changes, you can see a bit of acute changes, and this all fits in radiation. So please remember that radiation changes just go on and on and on. So both things can go together. Okay? Can you describe this?
Yeah. So I'm presented with a meal follow through, and I can see that there is a long area in the terminal ileum, which is narrow, and there is also mucosal thickening in that area, and proximal to that there is some bowel dilatation as well, and mucosal fold thickening.
Okay,
And
can I stop you there? This loop goes like this and then goes like this.
Yeah.
Why do you think something can happen here, or something?
There could be a big mass sitting there, which could have displaced the bowel loops, and causing disappearance.
What is this?
So again, there is a soft tissue density that is sitting in the on the right side of the abdomen, displacing the bowel loops, and I'm just thinking, and it's in very close proximity to the small bowel. It's in the mesentery, I'm thinking. I'm not sure. It could be. It hasn't got any desmoplastic reaction, hasn't got any calcification within it. And it's reaching up to the abdominal wall. And there is surrounding bowel wall inflammation as well.
So conclusion?
So could it be an inflammatory lesion there? It doesn't look like a collection.
Okay, so I'll take over. You see, this is lymphoma. Now, please remember that if you see thickened loop, long segment, and things like that, lymphoma is indifferential. Now, what is happening? That the lymphoma is sitting in the mesentery, and from the mesentery, it is going into the adjacent loops, and it will cause this, thickening and all those things. Now, you did well where you wanted to rule out a carcinoid. But the point is that uh, now look at this case. I hope it is projecting for you. Case 20 is projecting.
Yeah.
Is it projecting for you?
Yes.
CT scan? Okay.
Yes,
Now,
it is.
if you concentrate on this case, and this is a very important concept which you have to remember, this also is a case of lymphoma. And here, what is happening is, it will tell you that this soft tissue is a lymphoma. You did well in your case where you were trying to rule out a carcinoid. And carcinoid classically will also cause desmoplastic reaction. There might be calcification. But what happens? This lymphoma is sitting in the mesentery, and you can see how there is, striations around it. So this, you can see that it must be causing a bit of lymphatic or venous obstruction. And with that, you can see the adjacent bowel loops here, and why it will cause thickening, mucosal thickening. Here, look at this loop, and there is a bit of thickening of this loop. So anything which is sitting in the mesentery, particularly lymphoma, also carcinoid, can cause these kinds of abnormalities. Now, we go back to thickened mucosal fold in, I hope it is projecting for you this.
Yeah.
Okay. Thickened folds in non-dilated small bowel, and lymphoma is one of them. Okay, now you have picked up something sitting here, right?
Yeah.
And maybe something sitting there. And you already know that on the CT scan, what do you think is happening?
It's a desmoplastic reaction. I can see some stranding around the lesion, and then there's a stranding in the mesentery as well, and the bowel loops are pulled towards it. So it's a desmoplastic reaction, likely could be secondary to a carcinoid.
Okay.
Or a lymphoma.
Yeah, that's well done. I'll take over. Now, carcinoid is one of the most important exam case. Again and again and again it will come. Please remember that carcinoid in the GIT, the most common site is small bowel. And within the small bowel, the ileum is the most common site. You have to know the concept. Histologically speaking, basically it is an intramural tumor. So, and instead of projecting into the lumen, it might project into the lumen, it goes out into the mesentery, number one. Second concept is that if the tumor is more than 2 centimeter, 90% of the times when it presents to us, it has already got metastasis. Two metastases are important for you to remember. One is within the mesentery, and second thing is liver. If it is in the liver, it will be enhancing, arterially enhancing, and showing washout. And mesenteric lymph nodes, mesenteric metastasis might be larger. Very important point to remember. It might be larger than the primary lesion. So the examiner can show you a mesenteric mass and where is the primary, and the primary might be more subtle a small bowel. So that is the take-home point. So then what happens is that carcinoid will 80% of cases it might show a bit of calcification. Second thing is that carcinoids, they produce serotonin or kallikrein, because of which there is desmoplastic response, and there will be constriction of lymphatics or venous system, and the adjacent bowel loops might show a bit thickening. This is classical for carcinoid. And I have got a very, very good case here, classical exam film. I am conscious of time, but I think we'll continue for another 10 minutes or so. I know that it might be too late for people outside UK, but this is exam season and I think we have to crack on because I want to finish small bowel today. So maybe another 10-15 minutes. So now this case is too good for me not to show you. So it's a classical exam film and a beautiful case, and you can learn a few points from this one. So candidate 12, can you see this PAX case 5?
Yes. Yes, I can, yeah.
I will, my God, sorry for that. I have actually shared a wrong screen with you. Are you seeing this barium?
Yes, I can see this barium, yeah.
Okay, all of you, if you can concentrate on this classical exam film, for a long case, on a barium examination, you can see this filling defect. Subtle but definite because it is persistent and you can see loops here. And then on a CT scan, one thing is that there was a metastasis in the liver. And on these films, it was missed. Why was it missed? By the way, all of these are simple cysts. There is a metastasis which is sitting actually here where I'm pointing out. And this is just a portal venous phase. And key learning point here is that in the end, I will show you a liver window, and on liver window, you will see it. So that's the point to remember, but I'll come back to this metastasis. Now, as we go into the mesentery, you can see this mass. And with this mass is a bit of calcification. And you get excited that this is the primary lesion and you call it a carcinoid. And the examiner wants, okay, where is the primary? Actually, the primary is sitting here. You remember that barium? And this is classical because this is the primary, and this is an example where the metastasis is larger than the primary, and this is a usual behavior. And if you go to coronal, you can see it looks much bigger. That the metastasis in the mesentery, but look at this primary, and the primary is much smaller. Now, let me show you that liver abnormality. And this on an MR then proved to be arterial phase enhancement and then washout. So this was a metastasis. If you go back to the CT, and the learning point is always look at the liver window. And there is a lesion here, very subtle, but if you go to the liver window, which is width 150 and level 188 on our CT scanner, on our PACS, should I say, this is the liver window. So that's another learning point. Okay, we crack on with Okay. This number 12, you are still with us?
Yeah.
Okay. So you will continue till the end because we are just close to end. There was a lesion here, which is,
Yeah.
and on a CT scan, what do you think it is?
So on a CT scan, yeah, I can see that, and I can see some barium within it as well. So, is it like a diverticulum?
Actually, what has happened is that there is a mass within within the lumen, and this mass has got, the key here is, because of time I cannot give you in a viva format, but classical exam case, it is causing after 6 months it is causing a bit of intersusception. If you see, the mesentery is going in. Please remember that people think that intersusception is always acute. It can be chronic and it might not be clinically evident. It is a degree, actually, interception. Basically, the take home point is that this is a lipoma, and the key here was in the viva that fatty density, and the key thing was to see the Hounsfield unit. But what I am showing you that in an adult, whenever there is a bit of intersusception, you can see mesentery being pulled into the lumen. There must be a lead point. Okay, what do you think is happening in the mesentery?
So the mesentery appears misty in this one, and there is generalized increased attenuation in the central mesentery, and there are some enlarged lymph nodes as well, I can see, and I think this is just so this could be could be paniculitis, mesenteric paniculitis, or could be secondary to any inflammation.
Okay, very good. Now, that's very good. Now, mesenteric paniculitis is a very important exam case. Why? This is the current concept is that we now call it IgG4 related disease. So there is a spectrum, and in radiographics there are a few good articles, and Google New England Medical Journal and radiographics. I think there are 3 very good articles there. Read about IgG4 related disease, and this concept only came in 2012, if I'm not wrong, because now we have got, and why is it important for you for your exam? They will ask you long cases from the same concept. Previously, many things which we could, we were sort of, our concept was that these are unrelated to each other. Now we know, and there is a huge spectrum. Retroperitoneal fibrosis, mesenteric paniculitis, let's say autoimmune pancreatitis, sclerosing cholangitis. There can be nodules, in kidneys, in liver, etc. Thyroid orbitopathy, what we used to call pseudotumor of the orbit. Pseudotumor of the orbit. All of these things, they are in IgG4 related disease, and they will show you long cases. And here, the take-home point is that if you see here, classical description is that in the misty mesentery, you will see fat surrounding the vessels, but the fat will not displace the vessels. Fat will not displace. Another thing, please remember the concept, that the concept of the misty mesentery is that there is a bit of fat necrosis. And you can see these soft tissue nodules. These soft tissue nodules, radiologically speaking, they look like lymph nodes, but they might not be lymph nodes because they are foci of necrosis which give you this appearance. And in my experience, we have done advised some laparoscopies for a few of them. And when the surgeons, they go in, they don't see anything. So there can be lymph nodes and there can be explanation, which I have just told you. So this is from your previous Chapman, mesenteric paniculitis, 6.31. And this is another case, milder case. Candidate 12. In this case, there is, if you can see that there is a soft tissue lesion with some calcification in the mesentery. With that, there is something around the aorta. What will be your differential? Long case. It's a long case. I'll show you another film for this.
So there is a soft tissue around the aorta and some calcification within the lesion. Could this be some inflammatory, like fungal? No, there's no aneurysm here.
So I'll take over.
Sorry, I don't know.
Yeah, basically it is a case of IgG4 related disease. This soft tissue there is basically retroperitoneal fibrosis. With that, there is sclerosing mesenteritis. Please remember the spectrum. What happens is, the case which I showed you initially is more acute, but gradually there can be fibrosis and there can be calcification there. So calcification with surrounding soft tissue within the mesentery, the top differential diagnosis include mesenteric paniculitis or IgG4 related disease, which will be slightly more chronic. It can also be seen in carcinoid, as you have already seen. It can also be seen in treated cases of lymphoma. Please remember, treated, not untreated. So one can infer that this might be, treated lymphoma. So 2 plus 2 makes 4. And the same case can be given with findings in the orbit, which we'll cover in the head and neck. But having said that, this is, again, the same differential, lymphoma versus IgG4 related disease. Take home point is that orbital pseudotumor, the old terminology is now no more used. This is a case of interception on a barium examination, right? Can you describe the findings to you? I have given you the diagnosis.
So there is a filling. There appears to be a filling defect in the bowel wall. I can see that the bowel wall, that is very smooth filling defect, and it appears to be that there is narrowing of the proximal, and there is some dilatation of the distal bowel as well. So these findings are inconsistent.
Excuse me. What is this?
So this is the bowel which is telescoping into the other bowel.
Okay. Whenever you find, I'll take over. Whenever you find interception in an adult, think about a tumor. I have showed you a case of lipoma. We call it a lead point. Always look for a lead point. Whenever an adult comes to you with interception. In children, of course, it's different. Now, if you see here, there is a filling defect here, and this proved to be later on a metastasis. That is not my point that you call it a metastasis, you call it a mass. What is happening that this is the interseptum and this is interseptiens. So this loop is going to telescope into this. If you see the lumen of this interseptum, this is the lumen, and rest of course, there is a bit of constriction. There is a bit of barium in between the wall of the interseptum and the interseptiens, and which is giving you this spring coil appearance. So this is the lead point. So I have shown you this just to develop your eyes. This will be an easy case for you. And what is happening?
So there is a small bowel dilatation of the small bowels, along with a laminated calcific density in the small bowel loops as well, and some surrounding inflammatory change and thickening of the bowel wall. So this is because small bowel obstruction secondary to mass with the calcification within it, likely some gallstone.
Okay. So if you see here, this is, if you see gallbladder here, it is fistulating into the duodenum. And then it has gone, this is the stone here, and there is small bowel obstruction, classical case of gallstone IS. Is number 2 with us? Number 2? Okay, I am going to, yeah. Thank you very much, number 12. Very well done.
Thank you.
Number 2?
Yep.
Okay, I thought that I'll finish, but I've got still a few films. We'll crack on. So motivation is the key in exam, and I know it's 9:15, but we will finish it, whatever is left. Spot diagnosis, what is it?
So it looks like an outpouch in the wall. So it's a divertically.
So which border is it? You see, this is ileum. This is the mesenteric or the anti-mesenteric border.
It's anti-mesenteric border.
So take home point. What is it? And give me the diagnosis.
Scleroderma.
You see, this is the anti-mesenteric border. This is the ileum. This is correction. This is the anti-mesenteric border. This is the mesenteric.
Right.
And this outpouching is just maybe, small outpouching. And look at the mucosa. It gives you this V-shaped pattern here. The point is that this is a slam dunk case of what? You know it. Anti-mesenteric border, Meckel's diverticulum. Whatever is written here are potential viva questions which have been asked in the exam. And these concepts have come in the exam. Please remember that Meckel's diverticulum, this rule of 2 you must remember. Seen in 2% of population, located in 2 feet to ileocecal junction, length of 2 inches on average. Symptomatic usually before age of 2. This is a point to remember. Usually in children they will be symptomatic. But in adults, the main complication can be diverticulitis or intestinal obstruction. And the concept is that 50% of them contain ectopic gastric mucosa and 90% present with GI bleed in children. So in children, it is important. Okay, number 2, what is the investigation of choice here?
So you can do a Meckel scan, which is
Excellent.
a type of.
Right. So this, of course, I don't know much about nuclear medicine, and this will be covered later on by one of our colleagues in your nuclear scan session, but they ask it. It has come in the exam many a times, and you should know this. Technetium-99 per technetate scan is done, and it will only be positive if gastric mucosa is there. Otherwise, it will not be positive. And how much 50% has got ectopic gastric mucosa, but in symptomatic children, usually 90% of them will have it. Meckel's diverticulum on a barium study, Meckel's diverticulum causing an intussusception. Okay. Yes, please.
Okay.
If all of you can concentrate, it is very, this is a very good case, and many films have come in the exam from this pathology.
So the bowel appears to be significantly dilated and folded in together with multiple folds with a smaller distance between them. The bowel also appears to be of larger caliber than would be expected. And I think I can see some circulations in the right upper quadrants.
Okay, what is your conclusion?
So the appearances are typical for scleroderma.
Okay, very good. Now, let me tell you, scleroderma is a very, very, very important exam case, and it is, in MSK, you remember we did a lot of scleroderma for calcification and things like that. And similarly, GI involvement films come. Please remember that GI-wise, the most common organ is esophagus, but films-wise, they will not show you. they will show you, enema is very common where you will see circulations in the transverse colon, etc. But in small bowel, two types of findings can be seen. First of all, let's go back and see the pathology. You remember that there is muscularis propria in the gut. This muscularis propria, which is the smooth muscle of the gut, it is replaced by collagen and fibrosis. This is what is happening in the small bowel. And because of that, in the small bowel, there is a particular pattern which can be seen here. You know, because the circular muscles are affected, there is loss of capability of elongation of the bowel. At the same time, there is no loss of capability of dilatation. So there is crowding of folds in a dilated bowel loop of the small bowel. It is absolutely pathognomic. No other condition in the world can cause this. Please remember, if there is dilatation, there also will be increased distance between the folds normally. But this is a unique one where there is dilatation, but there is crowding of folds because of the concept which I have told you. So this film you have to remember. Second thing is that what can happen is that because of fibrosis, there can be outpouching of the bowel walls, and these outpouchings are more clearly seen at times in large bowel also. So these two findings are pathognomic for scleroderma. This appearance is known as hide-bound bowel appearance, synonym with hide-bound appearance of the skin of the patients, where it is just like cattle because it becomes very hard. And if you see here, the same finding on a plain film can also be shown. This is what we call pseudo-seculations, where this is the mesenteric border, this is the anti-mesenteric border, and you can see these localized bulges. Remember that this is fibrosis, and because of that there is bulges, and this finding can also be seen in the large bowel. Spot diagnosis. Number 2. What is happening here?
So there's multiple sacculations with thickening of the small bowel.
Which border is involved? Mesenteric, anti-mesenteric?
Mesenteric border. And mucosal irregularity.
So I'm not interested in mucosa. So your finding might be there, but what is this? You can see a neck hair, this. Okay, same case, CT scan after 1 year.
So there's some ischemic bowel, ischemic small bowel loops with 3 gas locules.
Why do you say ischemic bowel?
Doesn't appear to be enhancing.
You see, these loops have got contrast. So the point is that look at the mesentery. Okay, let me give you a hint. If this was sigmoid mesentery and there was stranding there and there were locules, how would you have called that?
Oh, so it's divertically of these.
Yeah, diverticulitis. So here, please remember that diverticulosis in the duodenum can also happen. And when there is diverticulosis of the duodenum, it will be on anti-mesenteric border. And the diverticuli do not have the muscularis inside. So whatever food goes in can stay there unless gravity-wise it comes out. So just like sigmoid diverticulitis, you can have duodenal diverticulitis. And then so this is not free air. This is air within the mesentery. And classical findings of jejunal diverticuli. Okay, last few films. This is a case of ischemic bowel. What is the key finding?
Okay, so there appears to be some gas in the bowel wall.
Okay, I'm not interested. Anything else?
The bowel wall appears to be thickened.
Anything else? So what I'm trying to teach you is that when you get a case of ischemic bowel, there will be, which is a very important exam case, there will be pertinent negatives and positives. So you have done well where you pick up if the bowel is dilated, number one, if there is thickening, if there is nematosis, if there is perforation, and in that category, what will be your pertinent negatives or positives? So some of them you have already pointed out. What is left now?
Okay, so there's thrombus in the SMA.
Excellent, well done. So always look for the big vessels and particularly SMA. So you can see that there is complete occlusion of the SMA. What is the finding? Ischemic bowel again. Pertinent negative or positive?
So hyperenhancement of the wall, gas in the wall of the small bowel in the pelvis, some free fluids.
You see, this is what we call small bowel, that string of pearl sign or string of bead sign. And this sign means that there is bowel obstruction. Anything else?
There's locules of gas within the pelvis, sort of inferior.
Else? No, I'm not interested. That is, intraluminal in the large bowel.
Okay, and the bowels also become featureless. There's a lot of fat stranding.
Right. The main thing is that if you see here, I wanted you to pick up this discrepancy. Look at these loops and it shows normal enhancement of mucosa. These loops are not enhancing. So other than nematosis, perforation, large vessels, always try to look at diffuse. So have a look at this one also. This one is slam dunk. You have already covered it. You have seen similar cases, which is nematosis because of small bowel ischemia, portal vein gas. This due to this is what we call small bowel, that string of pearl sign or string of bead sign. And this sign means that there is bowel obstruction. Anything else?
There's locules of gas within the pelvis, sort of inferior.
Else? No, I'm not interested. That is, intraluminal in the large bowel.
Okay, and the bowels also become featureless. There's a lot of fat stranding.
Right. The main thing is that if you see here, I wanted you to pick up this discrepancy. Look at these loops, and it shows normal enhancement of mucosa. These loops are not enhanced. So other than nematosis, perforation, large vessels always try to look at the bowel wall also. And you might get this kind of finding. In this case, when laparotomy was done, this was 8 feet of bowel which was necrosed. And this is from your new Chapman, small bowel wall thickening, and divided into 3 less than 6 to 40, and more diffuse. So have a look at this one also. This one is slam dunk. You have already covered it. You have seen similar cases, which is nematosis because of small bowel ischemia, portal vein gas. Last case of the day. 28-year-old male, motorcycle accident, multiple limb and chest injuries. Over to you. So this is the last case of the day. Those of you who are still with us, there are 500 people. Good. So if you can concentrate on this one, this has come in the exam quite a few times.
Okay, so there's hyperenhancement of the small bowel, which appears to be thickened, and there's also hyperenhancement of the adrenal glands with relative hyperenhancement.
Excellent. So what is your conclusion?
Shocked bowel syndrome.
Okay. So shock bowel syndrome is given here in your Chapman, diffuse more than 40, and these parameters should be in your knowledge. And I have seen in my experience many times candidates mix it up. They think that there has been what we call contrast in the bowel. No, there is no concept of contrast in a trauma case, right? Nobody has got the time to give contrast. So because it enhances like this. And these are the signs from literature which have been given for shock bowel. Hyperenhancement of adrenal is a bit of a subjective phenomena there, and similarly kidney. But always look for IVC and IVC, collapse of IVC. There are some measurements also if you read a good article in Radiographics, but there is no need for the exam. Basically, aorta is small, IVC is small, shock bowel, and this will be a finding which you might see in association with other things. So please remember that. And if you see a trauma case, always look at the small bowel and even make it as a pertinent negative for your exam.